This video provides a focused review on differentiating sympathomimetic and cholinergic toxidromes at the bedside, tailored for emergency medicine residents. In this session, we will cover recognizing the clinical patterns for both toxidromes, using specific frameworks to discriminate between them, and reviewing key management strategies. Both conditions can present with agitation and seizures, making them easy to confuse. However, they involve different neurotransmitter systems and require distinct safety and treatment approaches. Sympathomimetics directly stimulate adrenergic receptors, while cholinergic toxicity typically involves acetylcholinesterase inhibition, causing the body's own acetylcholine to accumulate. First, we look at the sympathomimetic toxidrome, characterized by catecholamine excess. These patients typically present as fast, hot, and diaphoretic. Common agents include cocaine, amphetamines, and synthetic cathinones. These substances increase synaptic catecholamines, resulting in a diffuse, exaggerated fight-or-flight state. Key clinical features include tachycardia, hypertension, hyperthermia, and dilated pupils. Importantly, while the skin may be wet from sweat, these patients lack the excessive secretions found in cholinergic poisoning. Next, the cholinergic toxidrome. This state is defined by acetylcholine excess, often causing patients to appear wet, weak, and frequently bradycardic. Toxicity usually results from acetylcholinesterase inhibition by organophosphates, carbamates, or certain nerve agents, essentially jamming the off switch for acetylcholine. Clinically, expect pinpoint pupils, excessive secretions like bronchorrhea and drooling, and muscle fasciculations. Be aware that tachycardia may still occur due to a nicotinic surge. Agents causing cholinergic toxicity range from pesticides and nerve agents to certain medications. Remember, suspected contamination requires strict decontamination before the patient enters the department. Here is a side-by-side comparison. Note the distinct differences in pupil size, secretions, and muscle findings that help distinguish between these two states at the bedside. The fastest tiebreaker for your bedside assessment is identifying pinpoint pupils, wheezing, and drooling, which strongly point to a cholinergic cause. For sympathomimetic toxicity, use benzodiazepines as the first-line treatment. Avoid non-selective beta blockers, as they can worsen hypertension by leaving alpha-mediated constriction unopposed. Management of cholinergic toxicity prioritizes provider safety, followed by the use of atropine to dry secretions, pralidoxime, and benzodiazepines for seizures. Provider safety is paramount. Cholinergic agents like organophosphates can cause secondary exposure in ED staff. Always decontaminate patients before they enter the department by removing clothing and irrigating the skin. Use appropriate PPE and coordinate with hazmat or disaster teams for any cluster presentations. For clinical pearls, remember that pupils are the fastest discriminator. Miosis suggests cholinergic toxicity, while mydriasis suggests a sympathomimetic cause. Do not rely on diaphoresis alone, as it can be present in both. Instead, look for bronchorrhea and fasciculations to confirm a cholinergic syndrome. Titrate atropine specifically to dry secretions. In summary, sympathomimetic toxicity involves catecholamine excess, dilated, fast, and hot, treated with benzodiazepines. Cholinergic toxicity involves acetylcholine excess, pinpoint pupils, wet and weak, treated with atropine and pralidoxime. Always prioritize team safety and early recognition to guide your bedside management.